Good morning and welcome to the 28th meeting of the Health, Social Care and Sport Committee in 2025. I've received no apologies for today's meeting. The first item on our agenda is for the committee to decide whether to take items 4 and 5 in private. Do members agree to take these items in private? Thank you. The next item on our agenda is to take oral evidence from the Minister for Social Care and Mental Wellbeing as part of the committee's inquiry into ADHD and autism pathways and support. And a welcome to the committee, Tom Arthur, Minister for Social Care and Mental Wellbeing, Gavin Gray, Deputy Director of Mental Health, Stephen MacLeod, Professional Advisor Mental Health, and Lynn Taylor, Professional Advisor Mental Health from the Scottish Government. And I invite the Minister to make an opening statement.
Thank you. And good morning. I welcome this opportunity to speak with the committee and contribute to this important inquiry. Across the UK and globally, we are witnessing a significant and growing demand for neurodevelopmental support and diagnosis. This is not unique to Scotland. It is an emerging issue in many parts of the world, with increasing pressure placed on systems that were not designed to manage this scale of demand. This is a complex issue. Neurodevelopmental needs span health, education and social care, and are shaped by a wide range of factors. A traditional NHS waiting list approach is not sufficient. What's needed is a coordinated, multi-agency response that focuses on timely, needs-based support and reflects the evolving nature of neurodevelopmental needs and the diversity of individual experiences. And the Scottish Government is committed to improving access to timely, needs-based support for neurodivergent people. For children and young people, our work is guided by the National Neurodevelopmental Specification, which promotes early, needs-led support through GIRFEC principles. However, rising demand has made implementation challenging. We've invested in pilots, digital tools and family support, and are now taking forward recommendations to improve implementation, supported by a newly established cross-sector task force. For adults, we have accepted recommendations from the Adult Neurodevelopmental Pathways pilot and continue to invest in support. Our Autistic Adult Support Fund and the work of the National Autism Implementation Team are helping to reshape services and improve outcomes. We also recognise the need for better data to inform planning and improvement. Work is underway with health boards and local authorities to understand service demand and provision more clearly. Finally, I want to stress the importance of finding consensus on the way forward. This inquiry is a vital opportunity to do that, and I would like to thank all of those families, professionals and organisations who have shared their experiences and insights. And I very much look forward to considering the committee's recommendations from the outcome of this inquiry. Thank you, Convener.
Thank you, Mr Arthur. And we're going to move straight to questions, and I'll put on record that I hold a bank nurse contract with NHS Greater Glasgow and Clyde. An issue that's been raised consistently throughout this inquiry, both in our written and our oral evidence, is that of waiting times, both for children and for an adult diagnosis. And I'm sure committee members will speak more later about adults seeking diagnosis. However, I want to ask specifically about children. Over recess, I met a constituent whose child has been waiting several years for a diagnosis. They spoke very highly of the support that they've been receiving from their child's educational establishment and third sector supports that they've been accessing. However, they feel that they're no further forward in gaining a diagnosis for their child. Something that they believe is absolutely vital going forward for them as a family. And I'm sure, Minister, you and your officials are well aware of the issue of waiting times. So what is the Scottish Government doing to tackle this? And how quickly can we expect to see waiting times reduce?
Well, thank you, Convener, for that question. It raises a really important point, and at the outset I want to stress that I fully recognise the importance that is placed upon assessment and diagnosis, both for an individual but for family as well, particularly in terms of understanding need around identity and validation, and of course with particular regard to ADHD, in some circumstances as well, medication. But I also want to be clear that what we want to ensure we are providing is a needs-led approach, recognising that, consistent with the national specification that we have for children and young people, a diagnosis is not a prerequisite for accessing support, and it should not be. Now, I'm conscious in some of the evidence that the committee has taken, particularly from the professional organisations, what the committee was being told, that there now is a perception that a diagnosis is required, and that as much as we have a needs-based approach on paper, the kind of understanding and the perception is, and the experience that has been relayed and conveyed, is that actually a diagnosis is what was being required to go and access support. That should not be the case. Now, we set out the national specification back in 2021. We undertook a joint review with COSLA. I updated Parliament just prior to summer recess, where I announced the establishment of a joint task force bringing together both health and education. That is going to be backed up by an additional £500,000 of investment in this financial year. And that is to take forward that work, which is ultimately, as I touched on in my opening statement, about having an approach that is consistent with GovFec, recognising that support should be available without a diagnosis, recognising the different circumstances in which a neurodevelopmental condition can present itself and the needs that have to be met within these different circumstances, for example, within an educational setting. Also recognising that often it can be the case that very small adjustments are all that are required to significantly improve the circumstances of the individual. So that is part of the work we're doing. As I touched on in my opening statement as well, there needs to be a recognition that the level of demand that there now is, both for children and young people, but for adults as well, is such that the conventional NHS waiting times list approach is not something that is going to be sufficient. And having that approach that responds to need is an absolute priority. But notwithstanding that, we continue to invest in our health and social care services, and we do so with the intent of ensuring that there can be that provision of diagnosis where that is required as part of a needs-based response. I don't know if any officials want to come in to add anything to what I've said.
In terms of tackling those waiting times, what's Scottish Government doing in terms of that? I mean, I hear what you're saying about the needs-based approach and the supports that can be put in for families and for individuals while they're waiting for a diagnosis. But the committee has heard evidence that actually a diagnosis for a lot of families and a lot of individuals is really key, that they really feel that they need to be able to access that. So in terms of bringing down those waiting times for an actual diagnosis.
Well, one of the points that I know has been reflected in what the committee's heard as well is the variation that exists across different parts of Scotland. And so part of the work that we're undertaking, as well as that engagement with Health Board and local authorities to understand the data they currently hold, and indeed to have a clearer picture of where variation exists. So that will help to inform the response that we take. There is obviously the substantive investment that takes place in terms of supporting our workforce, both in terms of headcount and also in terms of training as well and professional development. So that is already in place. But the point I would come back to is that we are working to establish that greater sense of what data is available and to provide greater clarity. But there's also recognition that the level of demand is such that we can't lose sight of the need for that needs-based approach.
Thank you, Minister.
You want to come in, Stephen?
Yes, please. I think the work of the task force really is the answer to your question, because the implementation gap of the National Neurodevelopmental Specification was identified in the review, and the task force has a number of actions, short, medium and longer term. There's some opportunities, I think, to improve, for example, the pathway for neurodevelopmental assessment for children and young people. Mr Arthur has touched on the data. The data is not good. We've got a really poor understanding of both the needs of children and young people and also their experience of service response. But I'm most optimistic about the opportunity to use the information that we gather routinely, particularly in universal services, health visiting and education, but also elsewhere, GPs, for example, and to contribute that in using the data better, digitising this data and contribute that to any future professional assessment. I think that is the big opportunity that we have, rather than starting again with professional assessments that don't carry any information for the families or universal services.
I think we're going to come on a bit later on in the session onto data specifically. So I'll leave that there and I'll go to Sandish Gohani.
Thank you. Thank you, Convener. Declaration of interest of practicing HSGP, and good morning, Minister. Minister, you spoke about better data. 42,000 children and 23,000 adults are waiting for an assessment as of March 2025. And we're talking years. We're not talking about a few weeks that these people have waited. Children are becoming adults and going to the back of the queue again. So you spoke of a needs-based approach, and you also were twice asked by the convener for a time frame when these waiting lists will come down. So I'll give you a third opportunity, Minister, to answer the question directly. What's the time frame that we're looking at to reduce the waiting lists?
I said in my opening statement, a traditional NHS waiting times approach it is not sufficient. The Royal College of Psychiatrists in Scotland, this was specific to adult cases, but they published a paper at the start of the work. And they, in terms of the increase in demand we have seen in recent years, spoke about it as unprecedented and unforeseen, and that the mental health system in Scotland cannot cope with it. But no mental health system in the world could meet that level of demand. And this is a global phenomenon. We're seeing it elsewhere in the UK, and we're seeing it internationally as well. So we have to rethink our entire approach. It has to be a whole system, whole society, and it has to be a needs-based approach. I do recognise the importance that is placed upon assessment and diagnosis, and I recognise the clinical value of that, in particular in regards to access to medication in the case of ADHD. But I also recognise that, and this is about the most important, that a step care approach that is needs-based can ultimately actually be most effective and most impactful in helping to ensure that people are supported and that their needs are met. So the notion of, given the level of demand, given the increase that we have seen even just in the last 5 years, is such that that approach, that particular paradigm and model is not one that is going to be sufficient. And that's why I just have to be, frank with the committee and echo the points that have been made by professional bodies in that regard, in terms of the need to rethink and have a whole system and indeed whole society approach.
So, Minister, when do we expect to see this needs-based approach?
Well, the point I would make with regards to children and young people, we have the national specification. We conducted the implementation review jointly with COSLA, updated Parliament in June with regards to that. The cross-sector task force has been established. That met for the first time earlier this month. There will be an additional £500,000 of investment this year. And that, as Stephen has set out, will have short, medium and long-term actions which will aim to improve the experience of children and young people. With regards to adults, we have accepted the recommendations previous to the Pathways report that was conducted by the National Autism Implementation Team, and we are working with health boards and partners to ensure that that is delivered. And on the point, in terms of being able to have a clearer understanding of the picture, there is our ongoing engagement taking place with health boards and local authorities with regards to data, which I appreciate, as the convener said, we're going to touch on later.
And there's a high prevalence of neurodivergent young people and adults that engage in the criminal justice system. What steps are being taken to strengthen a coordination and collaboration between health service and criminal justice agencies for these people?
I would expect, and this is a really important point about the need for collaboration across sectors. It's particularly important, of course, for children and young people with regards to educational settings and the responsibilities that are placed upon local authorities, as education authorities in that regard. But my clear expectation is that there would be joined up and comprehensive working that it takes account of people's neurodivergent needs. That is something that should be part of the sort of fully integrated response that we would expect in meeting anyone's needs, whether they're in an educational setting or in interacting with the criminal justice system as well. But the key principle has to be one of meeting needs and responding proportionately in doing so.
And for a final question is, looking with the criminal justice system, we also know that young people and adults with untreated ADHD are at an increased risk of developing substance misuse disorders. And that's something that's particularly relevant here in Scotland. What steps are being taken at the moment to ensure strength and collaboration, again, to ensure that these co-occurring disorders are addressed in a timely manner?
That's a really important point, and of course it's not just the risk of substance misuse, but also poorer mental health as well. And that speaks to the point with regards for a needs-based approach in the earliest intervention. And for children and young people, that of course, there's an opportunity for that to take place within an educational setting. And with having that needs-based approach, ultimately there can be a process of escalation up steps to ensure that needs is met, and that can of course include assessment and diagnosis as well. So having that integrated approach is essential, and having that early intervention is extremely important for prevention as well. So that is something that is fully recognised and reflected within the national specification.
Thank you.
Thanks, Convener. Good morning to you, Minister and officials. Sandesh Gilhani has touched on it already about, I suppose, the issues between criminal justice and then health and assessment. And you mentioned in your opening about health, education and social care being part of this and the whole collaboration required. We've had members' debates here about eating disorders, which also are linked with neurodevelopmental conditions. I've also met recently with the Dumfries and Galloway Ehlers-Danlos group, and that's an issue that was identified by them as there's coexisting, co-occurring conditions as well, such as dyslexia, ADHD. And so I'm thinking about, in terms of eating disorders like avoidance restrictive food intake disorder, it's all very complex. And that's why I'm assuming there needs to be collaboration, co-working, all that engagement. So I just want to highlight the complexity of everything.
Absolutely. I think you make a very powerful and profound point, Ms Harper, and it's something that we do have to bear in mind is the complexity and the need to respond to individual need. We speak of neurodevelopmental conditions as existing on a spectrum, and they will manifest and present in different ways. And as such, the response to that will differ based upon the individual circumstances. You also recognise the interaction with other conditions that can take place, and the fact as well that for people who have a neurodevelopmental condition there can be elevated risks of other conditions as well. So these are things that I think again reflect a need for that integrated approach, and one that is, and I repeat it again, responds to a needs-based approach. And that is something that is, I think, is very much reflected in the national specification. I don't know if, Lynn, if you want to come in.
So if we think about the complexity, and I'm a clinical consultant psychologist by background, and I know you've heard from other colleagues who've been to the committee from multidisciplinary backgrounds, I think you raise a really important point. The complexity of how an individual presents is often affected by our environment, our physical symptoms that we experience, our past experiences, and we know about children and young people and trauma, and ACEs, for example, can have an impact on how we present in our individual worlds and within society. And this means there's complexity, for example, and you raise a good point about ARFID, because we know that there's restrictive eating and hyperfocus in people with neurodevelopmental conditions can cause people to develop problems with eating and other things like anxiety. If you take, for example, specialist interests, quite often in my clinical practice I might have had individuals who have been referred for obsessive compulsive disorder, for example, because it has presented in that way, but through further needs-led assessment and individual kind of formulations, which describes an individual's stories of strengths and weaknesses, which is what Mr Arthur's talking about there in terms of a needs-led approach, helps us gather a picture about the whole person and the whole individual. And taking a needs-led approach doesn't mean that it doesn't lead on to diagnosis. It may, but for some individuals, having that sense of understanding of the symptoms they're experiencing and the complexity of that in their individual experiences at different points in time can really help be quite a validating and helpful experience in terms of outcomes and support and treatment pathways that they can access.
Okay, thanks.
It's just
colleague want a supplementary before?
No.
Emma's was a supplementary.
Okay, I beg your pardon. I'd like to move on and talk about the role of the private sector, and I think a few members have questions on this theme as well. There's quite a lot in here, quite a few dimensions to it. We've heard from some of the professional bodies concerns around quality, around whether services are being provided to a recognised and kind of agreed standard. Whether there's too much emphasis on single condition assessments that may miss other aspects of a person's situation. From the point of view of individuals looking to access services, obviously we've heard about the unfairness, but the fact that those private sector services are often going to be very available to people who are well resourced. Others either can't get access to them or in some cases find themselves going into debt in order to access those services. And also the frustration that even if they have accessed private diagnosis, that it doesn't necessarily lead to the ability to access the treatment that they want through the NHS. And I think from the third sector's point of view, if we think of private as being everything that's non-NHS, although the third sector may be in a position, obviously, to provide these services on a not-for-profit basis, which ethically I think most of us would be more comfortable with, and may often be doing it in a way that's rooted within the lived experience of people who have a greater kind of familiarity with the issues. It doesn't necessarily come with the stability of funding, and that can leave them feeling kind of taken advantage of in terms of what they can deliver. So, thinking about all of those aspects, what, in short, do you think should be the role of the private sector or the non-NHS provision? Is it something that you want to see expanded? Is it something that you want to see brought into the NHS so that the NHS is providing for people's needs and they don't have to resort to the private sector? Where should this be going?
I thank you for your question, Mr Harvey. And you certainly summarised a lot of the issues and a lot of the complexity. And I know a particular issue that has been raised with the committee, and I think will probably been raised with all of us in our capacity as MSPs with our constituents, is the issue of what is described as shared care, where someone obtains a diagnosis within the private sector and then finds that they're unable to obtain indeed there's a prescription that comes with it, they're unable to obtain that via the NHS. And I think the committee's familiar with the range of reasons and some of the concerns that have been raised around assurance and quality and confidence. I think, if I recall correctly, I think the committee took evidence with regards to potential online assessments taking place from providers out with Scotland as well. So the committee, I appreciate, is familiar with the range of concerns that are raised. Firstly, I recognise the point it's made about why individuals are seeking diagnosis in from the private sector, because it's been touched on at the outset in question from the convener, the current length of waits in certain parts of Scotland. The point I would want to come back to is that focus in rethinking the system and moving away from thinking about this through the paradigm of an NHS waiting list style approach to one that is ultimately based on needs, recognising that the importance that is placed on assessment and diagnosis, but also recognising that significant help can be provided, indeed should be provided, and need can be addressed in many cases without a diagnosis. And if we get that shift in terms of potentially as a way of helping to ensure that people are receiving support, initially they may find that meets their needs, and consequently there's not a requirement for a diagnosis, which can have an impact as well, of course, in demand overall. And I'd want to caveat what I'm saying just to be absolutely explicit, so there's no way in which I'm being misconstrued that I in any way do not recognise the importance that is placed upon diagnosis. But there is a need ultimately to be focused on meeting needs, because as you touch upon, a diagnosis in itself in many cases isn't necessarily going to lead to any other interventions. I appreciate the points around certainty, identity and validation, but it doesn't itself in many circumstances, out with the question of medication, actually lead to a situation where there's any additional service or support that can be provided that cannot be provided without a diagnosis. So that's part of it as well. With regards to the specific points around shared care, this has been raised with me, I think, on more than one occasion in the Chamber. We've been having engagement with the Royal College of GPs to have more of an understanding of this, and we're doing a bit of work. But what I would want to ensure is that every individual who requires the support of our National Health Service in any way can receive the support and help and care that they require from our National Health Service without the need to go private. That is what I would want to see. But my particular focus here is ensuring that our system is responding to the need of individuals, recognising this unprecedented increase in demand. I want need to be met within our existing health and social care system and in our educational settings. So to, I suppose, respond to your question directly, I am not here to go and advocate for an expansive and increased role of the independent sector, though I recognise individuals are at liberty to exercise the right to use that, and recognising the challenges that have emerged around shared care. We are having that engagement. Can I just tease out a little bit what you're saying, because you said that you want people to be able to access the support they need through the NHS without needing to resort to going privately. But previously you'd been making a distinction between support and diagnosis, which may lead to treatment, which may lead to a prescription. Now, support is something different, something valuable, but those refer to different things. So are you saying that you want everyone to be able to access not only support in the broadest sense, but also to be able to access diagnosis and, if appropriate, treatment through the NHS? Well, of course, I want to ensure that every individual who requires diagnosis and treatment through the NHS is able to access that. That is the founding principle of the National Health Service.
Given the scale of demand that you've described, is that something that can be delivered? Or, for example, should the government be looking to more sustainable third sector funding, which is on a not-for-profit basis, but which could help to expand capacity in a way that is specialist and perhaps more relatable?
Yeah, I think the role of the third sector is hugely important. You'll have heard, I know you took an evidence session with many of the organisations that have worked and engaged with the government over years, and so whether that's the funding we provide to Scottish Autism for the Autism Advice Line, the Autistic Adult Support Fund, the additional resource that we're providing.
Forgive me, I am going to take out the difference again between those wider support services and diagnosis and treatment. Do you see a role for the third sector or other parts of the non-NHS sector
they play
in meeting the need for diagnosis and treatment as opposed to wider support?
Well, I would just be conscious of, and I know it's not your intention at all, Mr. Harvey, but just in terms of treatment sort of almost is suggested of something that is to be cured or to be remedied.
No,
I know that's not
medication needs to be prescribed,
but in specific cases, with regards to and consistent with clinical guidelines as well. We know that for many people with a neurodivergent condition, the support can be often provided through very minor and straightforward environmental adjustments, through peer support as well. So on those particular points, I think the role of the third sector is absolutely vital. We do tremendous work, and I recognise some of the challenges that have been articulated to the committee, and also in relation to some of the decisions.
I'm not seeking to take away from the value and importance of that at all, but we have heard a significant number of voices saying diagnosis is hugely important for a range of reasons, including to access prescription medication in certain circumstances. And I'm not yet hearing from the government how it intends to meet what is you're describing yourself as a substantial demand which is currently unmet.
I think the part of that has to be and I tried to set this out in my opening statement, is to move away from that paradigm of a traditional NHS waiting list approach. Again, I appreciate you took evidence from the Royal College of Psychiatrists in Scotland in relation to their paper they published on adult neurodevelopmental services at the start of this month. They made the point that the system in Scotland cannot meet that need, but no system in the world could meet the level of demand that there now is. Just in terms of thinking about what is required and what would be needed to do so. So there has to be a focus on meeting need, a step care approach, what is consistent within the national specification for children and young people being consistent with GIRFEC. It's important to have that focus in meeting need. I recognise as part of meeting need, assessment, diagnosis can play an important role, but diagnosis is not and should not be a prerequisite for obtaining support. And that is, I recognise, where there is a challenge at the moment around implementation, as Stephen touched on, which is why we established the cross-sector task force, why we're putting in the additional investment. Will you want to come in, Stephen?
Just perhaps an example. I think I understand your question, Mr Harvey. And so our view is that if we gathered the information that is currently routinely gathered, particularly for children and young people, in a more systematic and structured way, and had better ways of sharing that information with consent of families, then the assessment and, for some people, diagnostic pathway would be much more efficient, and we'd use the resources that we already use just now, we already have in place. I think it touches on Mr Arthur's point about the estimates, you know, the numbers that colleagues have talked about today, the 42,000 or the 23,000. We're not 100% sure what those numbers mean. And in children's services, we know that there's lots of universal contacts and supports provided to families. And families, that information could travel with the family or young person and contribute to the assessment and any diagnostic outcome much more efficiently than the traditional NHS waiting times approach. I think that's what we have to move away from, that we have a standalone offer where we start all the information gathering from scratch without any of the continuity or context of the young person coming with it. That's probably the biggest single change that we could make to the way that we approach this.
I know that other members want to come in on this theme, so perhaps my last question would be, by what time, by what date do you think that moving to this different model that you've described is going to make a substantial difference to people who currently are left waiting or feeling forced to go to private providers if they've got the money?
Well, there's work already underway. I mean, I think the point touched on in terms of the actual, I suppose, the policy and the framework and children and young people with the national specification is in place. What we recognise was that implementation gap, hence the work I previously referred to. That is underway. I want that to move at pace. We are working with health boards in terms of the implementation of the findings of the Pathways report. And I made reference to the Royal College of Psychiatrists in Scotland paper. We're giving very serious consideration to it, but I would reiterate points that I've made previously in the Chamber, is that we very much welcome the paper, its contribution. We think it makes a very important contribution to the discussion, and there is much in there that is worthy of very serious consideration. So I would want to give the undertaking to the committee that this is an absolute priority for me, and that we are going to be working at pace to make as much progress as possible, hence the additional investment that we've committed to within this financial year.
Thank you, Camilla.
Thank you, Mr Harvey. Elena Whittam.
Good morning to yourself and the senior officials. I guess I just want to explore this area a little bit further, and thanks to Patrick Harvey for starting us off in it. And I want to think specifically about an individual constituent that I have. This is a young person who has had no access to any waiting list despite repeated referrals by his GP. And finds himself in a situation where he doesn't have the co-occurring mental health issues that's required to go on to the specification as set out in Ayrshire and Arran. And his family do have the means to seek a private diagnosis, but their local GP practice has a blanket ban on not undertaking any such shared care arrangements. So I'm just interested to understand, how does the government envisage a situation or a system whereby that type of situation can be addressed in a way that I think the Royal College has actually set out in their own paper, talking about the fact that not one agency or model is actually going to be able to do all the work that we need it to do. So in situations where we have seemingly blanket bans in GP practices about not undertaking any shared care, not on an individual clinical assessment to that actual patient, but they're just not entertaining it. But their own referrals are not meeting the threshold to get onto a list. You then have young people who are essentially hidden in a system and not actually having their needs met. So how do we address that type of situation?
I think in terms of what should happen is what is set out within the national specification. And the points that Stephen made about how we can more effectively utilise the data that is gathered from the innumerable interactions that are taking place already within the system, for example, within educational settings. That is a challenge, to public bodies and to government about how we more effectively utilise that data. Hence, we have had that engagement with health boards and local authorities and working to consider not just the data that's available, but how it can be more effectively applied. There is a work that's been taken forward by the cross-sector task force on improving the implementation of the national specification. So that work has been committed to and is now underway, specifically to respond to the circumstances that you've articulated, where a young person is not necessarily receiving the support that they should be receiving in their particular area. So that is, I would say, in terms of responding in a way that recognises the complexity and is also, I think, consistent with a lot of what the Royal College of Psychiatrists have said, recognising that there isn't one particular model. There's going to be a multitude of different approaches, recognising the different circumstances that people find themselves in, the different settings and the particular needs of the individual. So that is, I think, in terms of where we're at, is that the policy and the framework is there. It's a question around implementation, hence the establishment of, hence the joint review on implementation and the subsequent establishment of the task force and the additional investment. I don't know if there's anything you want to add, Stephen.
I think this is very specific to local authority areas, because I think that the key for children and young people is the children's services planning arrangements, the relationships between different children's services, and as you and your colleagues will know, that can vary from local authority area to local authority area. So the government specifying the standards to reach, but I think the implementation challenge is local. And I know that my colleagues in Ayrshire and Arran have got 3 sets of relationships to negotiate, and are trying to have those partnership working arrangements with particularly education colleagues to develop the pathways that support the neurodevelopmental specification. That will vary from area to area depending on local circumstances, but I think I'm most optimistic about the chance of local solutions, particularly where head teachers are involved in those discussions, because in my experience head teachers understand the needs of their school role and can make decisions about the changes that they need to make within the school to most closely meet the needs of children and young people. So there's a macro and a micro level, and I think we probably know less about the micro level at this stage than we would like to.
I think in that specific instance, the school have been very proactive and very supportive of the family, and they've actually also put information forward to support the need for an assessment. I've got one other question around about shared care, and I suppose it's around about comments we heard at our last evidence session, and there was Wild West was used, and at that point I did feel compelled to come back in at the end of that session to ask some questions around about the value of such private providers, especially where we have them based in Scotland, regulated by Healthcare Improvement Scotland, also partnered with a lot of the local areas to deliver assessments. Do we see a value in that sector itself? Where we have it based in Scotland, they maybe are conducting online assessments, but they're subject to all of the same checks and balances as any other practitioner in Scotland who might be rooted in the NHS itself.
I recognise the importance that many people will place upon the independent sector, and those who have the means to do so may choose to exercise the rights to utilise that. When it comes with regards to the interaction with the NHS, of course, decisions are ultimately clinical decisions to be taken by the clinician who's in charge of the patient's care, and that's a well-established and well-understood principle. But with regards to the situation that we find currently where there can be variation with regards to describe the shared care arrangements in different parts of Scotland. We are having that engagement with the Royal College of GPs to explore what to deepen their understanding of the issue and consider what any potential options or responses may be. But I would obviously stress that I recognise ultimately the primacy of the decision making being in line with the relevant lead clinician.
Thank you.
David Thomas.
Thank you, Convener. Good morning, Minister and officials. In what ways does the Scottish Government ensure that national specifications are implemented at local level?
It really gets to the sort of heart of the challenges that we've been, I think, just previously discussing this morning. We obviously seek beyond in terms of the process of developing a national specification. Obviously, that's a collaborative endeavour. We recognise that in the case of the national specification for children and young people, there were challenges around implementation, inconsistency, hence the joint review, hence the establishment of the task force. So that work will go forward with the aim of ensuring that the experience of individuals engaging with services is consistent with what is set out within the national specification. So that is beyond the engagement that regularly takes place between government and local partners. There is that specific dedicated work of the task force, and the task force had its first meeting earlier this month.
Thank you, Minister. How can NHS boards be supported to move towards improved pathways and assessments while dealing with long increased waiting lists? And the reason I'm saying is some of the evidence we were given earlier in the sessions was, and I'll quote, good practice don't travel well. And as you know, there's 32 local authorities out there and different NHS boards. How could we improve that good practice?
I think it's a really important point. And certainly in government we try to support boards and local partners to take forward best practice. So there's the work that was undertaken with the Pathways report by the National Autism Implementation Team, which was published a couple of years ago. Government accepted the recommendations from that and has been working with health boards to support implementation of those recommendations. But I recognise that there is variation currently, and while recognising that day-to-day operational role that health boards have, we are committed to continuing to work constructively with boards to achieve that level of national consistency which people across Scotland expect. I don't know if any officials wish to add anything. You want to come in, Stephen?
As part of the development of the national specification for children and young people, we commissioned 5 tests of change. I think we understand a lot more than we did then about the answer to your question, effectively what works locally and what are the challenges. It's a combination of things. I think the local leadership and commitment to deliver the change is essential. Some of the resources, not always in people and money, but infrastructure resources, good practice, tools that have been effective elsewhere. And I think that the last thing is the scrutiny. I think it's always helpful for local areas when ministers and committees and others are interested, including local government committees. So the reports going from the task force, the tests of change progress, was really effective in encouraging and informing politicians and also getting more support for further rollout of the very small tests of change. And in some areas they've taken those lessons and they've done much more with them.
Around the cross-sector task force, how will its progress be measured and evaluated, and how will the existing money and additional money funding be evaluated as well?
Well, the review set out a range of actions, short, medium and long term, which will provide a means of assessing progress. The task force is taking forward that work. With regards to the additional resource, it was committed to, I hope to be in a position relatively soon to set out how that's going to be deployed, and will this undertake to keep Parliament informed of the progress that's made. But as I said earlier, the task force has already met for the first time earlier this month. and happy to continue to engage with Parliament to ensure that it is kept up to date as and when outputs are articulated.
No further questions?
Thank you. Brian Whittle.
Thank you, Convener. Good morning, Minister. Good morning to your officials. I will not be surprised to hear, Minister, want to talk about early intervention and prevention of harm. So if I can start off by, how that early intervention, that harm prevention, will be built into sort of the neurodivergent services for assessment and support for both children and adults.
I think it's such an important point. I mean, I think an interesting reflection on the significant increase in demand, as the committee will be aware from the work it's undertaken, is amongst adults, many of whom there could be a multitude of reasons. Perhaps it was a child being assessed, which maybe prompted some thought and reflection with regards to their own circumstances in life, which has ultimately led to them to take a decision to seek assessment and diagnosis. And having, through engagement and encounters and conversations and reading testimony, it speaks very powerfully when someone's perhaps coming to having these reflections later on in life, perhaps in their 40s, and what would the difference have been to have had that early intervention, to have had that diagnosis or awareness at a much earlier age. I think there's something quite powerful in that, and it speaks to the importance with children and young people and the approach that we've set out in the national specification and being consistent with GIRFEC. We're taking every opportunity to identify need at the earliest stage, because we know that addressing, as you've set out very clearly, what a passionate advocate for prevention you are, Mr Whittle, but the opportunity to recognise that need and to respond to it at the earliest stages of vital importance. So that is ultimately reflected in GIRFEC, it is reflected in the national specification. I think the points that Stephen has set out earlier with regards to how we can more effectively use the data that's already within the system is an important one, and I think that is something that will be reflected in the work of the task force in addressing the challenges we've seen around implementation. I don't know if there's anything you want to add, Stephen.
I'm remembering we did some work on the previous task force, Children and Young People's Mental Health Task Force, in 2019, and the University of Birmingham did a study that said around 3/4 of mental health problems with adults are identifiable in childhood. And Professor Gilberg and Professor Minnis also provided some evidence to us that we could know possibly half of the children and young people who required neurodevelopmental supports by around the age of 8. And I think it speaks it speaks to your question that I think if we got better at identifying and supporting families at a much earlier stage, we could actually shift the whole life course of presentations in the way that the Minister describes. Not that there will not be later presentations, but we could get ahead of this and actually support children and families prior to the transition to adulthood. So I think that's a great ambition, and it's also the potential for changing on a public health level is there.
I have a really specific interest in this. I've coached people with autism and FASD, not ADHD, but FASD, and recognise you talked about a whole system approach, Minister, which I wholeheartedly agree with, and that coaching structure, that outlet for energy, if you like, and that ability to mix with others in that environment, in general, is a very positive thing, especially in our youth. But what COVID did was take all that away, and the impact was very poor in general on mental health of the squad that I coached, but very specifically on somebody with neurodivergence, the impact was miles worse, and the way in which their lives were impacted, was considerably worrying. So when you talk about a whole systems approach and we talk about prevention of harm, in terms of opportunity in general for kids to participate, but specifically in neurodivergence, and I took this up, I raised this with some autism, ADHD, third sector, and with the Royal College of Psychiatry, expecting a major pushback, I have to be honest. And they were very supportive of the approach, and absolutely agreed that one of the reasons we are having such a high level of increase of presentations of this is, one, we're better at diagnosis, but two, we've taken away a lot of that opportunity. So, a long-winded way. In terms of a whole systems approach, how are you working with other departments and other portfolios in the government to deliver on that whole system approach? Because it is a whole health approach.
On that whole system approach, that's specifically why the task force is jointly chaired with representation from health and education, reflecting that. But I think in certain respects it goes beyond just a whole system approach to a whole society approach. And that's more, look, cultural change is more difficult, but having to move to a more accepting and neuroaffirmative culture within our society, I think, is going to be important as well. And certainly a lot of progress has been made. I think the significant increase that we have seen in demand, there were a number of drivers behind that. There has been a widening of the diagnostic criteria, reflecting more developed and nuanced understanding of neurodevelopmental conditions. There's also been a tremendous amount of work around awareness raising and tackling stigma, and that again has created an environment where people are much more willing to come forward, both with regards to themselves and with regards to their children as well, and that is positive, and I think it reflects that societal shift that is taking place. I think the specific point around the system, though, and it comes back to the point that Stephen set out, was about how we more effectively utilise our existing resources. If we think about all of the ways in which children and young people are interacting with the state, whether that's in an educational setting, a healthcare setting, is ensuring that work is coherent and is holistically centred around the needs of the individual. And that is reflected in the national specifications, reflected in GIRFEC, and it comes back to that point just to reiterate about why, in terms of the work around implementation in the joint task force, there's that dual representation from health and education.
But and I know that you buy into this, Minister. But in terms of the population health framework, it's about how do we make sure that there is that opportunity for neurodivergent people to integrate and to participate. And the reality is that has reduced. And I say I'm almost reverse engineering it from COVID, because of the impact of seeing what happens when that is withdrawn. So for me, it seems to be if we went the opposite direction and produced that public health framework that says you will be able to integrate, there will be opportunity for you to participate, not just in sports, but in any kind of activity at all. What are you going to do to ensure that sort of reverse engineering, if you like, is real? It's not enough to say that you understand it. It actually has to be done. I
think that question around implementation, if you consider the statutory framework that our education authorities operate under, an inclusive approach, and one where needs are assessed and support is provided based upon needs, are already within statute. They are requirements in terms of how our education system operates. So the challenge has been a question around implementation, and that is at the forefront of my mind. It's important to have statutory obligations, but what matters is what the experience of the individual is when they're interacting with a particular service, in this case in an educational setting, and that's why we're taking forward the work around the implementation review and the joint task force. So that is reflective of the need to address the points that you're making, Mr. Whittle, but I would also recognise as well that we cannot look at support for people who are seeking support for people who are seeking assessment or support for a new developmental condition. We can't just look at it in isolation of the wider society, and by that they are there's the impact of the pandemic, I think, has been profound, and it will have affected people in different ways. But there is also the significant cultural shifts that are taking place in society. I think, again, I know it's an area that the committee will have given consideration to in its broader deliberations around mental health. But, for example, now, just as one particular factor, but the changing habits around our use of mobile phones and social media, that is having a profound impact on society, and it will be having a particular impact for people with regards to neurodevelopmental conditions. Some of that will be positive in creating awareness and prompting people to seek more information and support, and some of it may be less positive. Again, these particular dynamics apply across a range of different, aspects of society. So I take the point that in considering our approach, it's not just a whole system in terms of responding to neurodevelopmental need, but it's seeing that in the rounds in a population health aspect as well. So we are taking specific steps to improve implementation of the existing standards that we have set out, and we also recognise that broader population health aspects as well.
I think I'm going to push this because it's the increased devastating effect that we witness of isolation on neurodivergence, and that how unbelievably important it is to be able to be part of something. And we heard evidence to say that online is also a way in which communities can be built. So it's not all bad. And what my point to you, Minister, is that as a government, how are you making sure that all portfolios recognise the importance of ensuring that isolation is tackled?
I come back to the point with regards to the specific work of the task force and that joint review. So that's partnership working with local authorities via COSLA and the Scottish Government on the review, and then there is that joint chairing of the task force, NHS, health and education as well, recognising that this cannot be siloed. It cannot simply be a response from one particular department, nor can it simply be the Scottish Government. It has to be a whole system, and of course local government and local partners and health boards have an absolutely vital role to play. And there is also, and it's the point that Mr Harvey raised, is the profound positive impact of the third sector as well, particularly around peer support and helping to tackle isolation and provide opportunities for engagement and socialising. So we recognise that there's a range of different partners who can provide support and collectively need to work together in a coordinated fashion to ensure that needs are being met.
Thank you.
Thanks, Convener. It's just a quick question to pick up on what you were talking about with stigma, and also in helping support people in the work environment, for instance. I'm a former NHS educator, and we had a TURAS platform from NES, and NES created a Foundations of Neurodiversity Affirming Practice webinar in 2023, and that was delivered. And it's recommended for all health staff and social care staff, but they don't seem to be tracking whether that has been delivered or what the numbers of delivery of that education in an ongoing way. Because it's fair enough saying that the recommendation is it's a starting point for all staff, but does that mean it is delivered to all staff? And it's a great way of, creating a neuro-affirmative work environment so that people like myself, when I was a clinical educator, can understand what works best for people who might be autistic or might have ADHD. So is there a way that we can find out or how that education is being delivered by NES at the various health boards, I suppose?
I think it's a really important point, and in recognising that particular resource that's available. And I'd also added it's available at 3 levels, so there's an opportunity to further develop knowledge and expertise. With regards to the uptake and utilisation of that, I do not have any data or statistics at hand, but I'm happy to take that away, and I don't know if it will be something that the committee will be considering with regards to its recommendations. But I think, as a point, I mean, I touched upon data earlier on, which was very much focused upon the number of individuals seeking assessment, but I think another point around data is the uptake of that particular resource is a useful one. So I appreciate that may be something the committee will again consider as part of its recommendations, but certainly as an output from this meeting, I'm happy to go and take that away and discuss with officials, because I think it's an important point.
Okay, thanks.
Sweeney.
Thank you, Convener. We've heard from previous submissions of evidence from various stakeholders about a high level of variability in support information resources, particularly for neurodivergent people who are waiting for a diagnosis. It seems to be a bit of a doom loop from what we've heard from various experiences, that we know support should be available without the need for a diagnosis, but in practice you can't get that without the diagnosis. We know, for example, education authorities often use the diagnosis as a gatekeeping exercise to ration resources in the context of funding constraints. So how does the Minister propose that we should address this fundamental problem of this doom loop that repeatedly comes up? And how do we open up a much wider discussion on the lack of support for prevention for neurodivergent people across the NHS, or at least signpost people to the relevant support whilst they're waiting on a formal diagnosis?
Well, firstly, my clear expectation is anyone who is waiting for assessment should be sensitively signposted to support that is available, and would reiterate that point that diagnosis is not and should not be a prerequisite to get support, and if education authorities, local authorities, should not be using a diagnosis for gatekeeping to access services. They have clear obligations and statutes around meeting need and ensuring that that is delivered in a way that is consistent with the principles set out. So, but I recognise, having said that, that the evidence that the committee has taken has been, as you have articulated, Mr Sweeney, and it comes back to that point around the question of implementation, and I won't rehearse the points that I've previously made with regards to the review and the joint task force, but that is the principal way in which we are responding to this.
Okay. There was an interesting point made by the Child Head of Psychology that is recognised there are areas of good practice in Scotland, so NHS Lanarkshire and NHS Lothian were identified by their submission as having developed a bank of digital resources offered to those waiting to be seen. However, this is not the case across the country. So I wonder, does the Minister share the view that once for Scotland, Scotland's standard should be adopted, and that there should be rigorous benchmarking of where there is good practice and then trying to bring that to a national standard?
I think, well, of course, with regards to the specific, the children and young people, we do have a national specification, and I would expect to see consistency. And with regards to the work that we're undertaking with health boards, it is my strong desire that we achieve consistency. In saying that, I recognise there will be variation which will respond to the needs and assets of different communities in different parts of Scotland, and that's particularly important when working with local partners. So variation in that regard can be important, but that's about variation, how a service is delivered and what assets are utilised to meet, which should be a consistent national standard, because ultimately that's what people expect. I recognise there's variation at the moment. That is something that we are working to reduce, and working in partnership with local government and health boards. And there is, I think, clear sort of policy framework set out about what the standard should be. The question now is one of implementation, being able to achieve that.
Just wonder if the Minister could elaborate on your point around that. How do you ensure it's delivered? What mechanisms do you have at your disposal within the civil service to benchmark, assess and hold accountable authorities for not complying with standards?
Well, I have to operate within the sort of constitutional and legislative framework that exists with regards to the autonomy of local authorities ultimately. And indeed, I have to operate within the legislative framework, which ultimately Parliament is the custodian of. And of course, while it's entirely a matter for Parliament, for individual committees to determine what particular topics and matters they wish to pursue. I do recognise that committees such as this one, and say that as a former member of the committee, can play an extremely important role in the scrutiny work that's undertaken of individual health boards and health and social care partnerships, for example, as well. But with regards to where my responsibilities directly sit in the work that I'm undertaking, it is one ultimately of collaboration, building that consensus, and through having a national standards is working to ensure that that is what is delivered on the ground, and where there are challenges, working collaboratively and in partnership with the relevant body to seek to remedy that. Is there anything you want to add, Stephen?
Yes, thank you. I know we've talked a lot about the task force, but I'm just looking at the list of short, medium and long-term actions, and I think it picks up some of Mr Sweeney's questions. So, for example, we've talked about the data is poor, so getting a better understanding of the agreeing data points and understanding the need, the support arrangements in each area is one of the longer-term actions of the task force. There's also the sharing of good practice. I think many of our colleagues out there would want to do this, and they would want to know who's doing it well and can we use some of the tools that they've developed. So another commitment of the task force is to gather that information and make it more available in a digital way for areas that want to build on good practice elsewhere. But I think at the end of the day, we have to have better data on outcomes for children, young people and families, so that we can all be accountable. So all of the statutory bodies, all the players in this game can be accountable. And until we have that data routinely available, it would be difficult to do that.
Do you feel that there's a balance to be struck around the clinical nature of diagnostic pathways? Is there alternative examples around the world or elsewhere that you've seen that could offer a better structure for Scotland?
The committee, in terms of some of the evidence that's taken, was consideration of some multidisciplinary teams and that partnership approach. I think the point that, again, I'll come back to it now, but I think it's a really important point that Stephen made about the utilisation of the data we already have within the system and the range of opportunities that there are to develop an understanding of an individual's need. And again, particularly in the context of children and young people, is something that we have to more fully utilise. But in terms of international examples, I suppose I would come back to that, the comments contained within the Royal College of Psychiatrists in Scotland paper, which was recognising that this is an international phenomenon with significant increase in demand. And if I recall correctly, in their words, there would be no sort of system in the world that could realistically respond to the level of demand that has taken place. So we're certainly open to examples of good practice, but I think what we have in Scotland through the work of the National Autism Implementation Team, the work of the national specification, what is contained within the national specification is correct in terms of policy, having that needs-based focus. Question now is one of implementation, and certainly in terms of looking for other approaches that we can add to that. As I touched on earlier, we very much welcomed the paper from the Royal College, and we're going to give very careful and detailed consideration of its proposals.
Okay. Are you aiming to get to a point where you have a clear picture of what the national baseline should be and how each local authority, each IGB is performing against that national baseline? Is that what your ultimate goal as a minister would be?
I think, again, in answering the question directly in terms of the spirit of what you're saying, then yes, but I just want to caveat with the points I made in my opening statement around not conceiving of this in this sort of traditional NHS waiting times sort of paradigm, but in terms of ensuring that there is broader consistency across Scotland and people's experiences, then yes, I think that is something that we need to continue to work towards achieving. And being aware, as has been touched on, there are examples, I know the committee will have heard of good practice. The challenge is ensuring that good practice travels better than it perhaps currently does at the moment.
Okay, thanks.
Carol Mochan.
Thank you, Convener. I would like to just ask a wee bit about workforce and training. A previous minister gave evidence to the Equality, Human Rights and Civil Justice Committee in 2024, recognising that perhaps we had to look at this across the boards, the NHS boards. And I wondered whether the minister could give us any feedback on how they are working to encourage NHS boards to develop their workforces together, particularly around that lack of certain professions or training that is needed for people.
I think we touched, thank you very much for your question, Ms Mockin. We touched upon some of this in a response to an earlier supplementary from Emma Harper. Made reference to the resources that are available, and if I recall correctly, I think that was with the participation of NATE in terms of some of the development of these resources as well, and the fact that they operate at 3 levels. So there is resource in place. The point that Emma Harper raised, which I committed to taking away and giving further consideration to, is with regards to the utilisation of these resources and being able to assess the impact that it's having. So I think that's a valid point, and one that will take away and give further consideration to, and will be very keen to see if this is something that features in the committee's report. In terms of sort of workforce development, I don't know if there's anything anyone wants to add.
I think maybe just in terms of some of the wider context as well, we published obviously earlier this year the Service Renewal Framework, and I think a lot of the issues that we're dealing with, in this inquiry there's a lot of challenges, as you'll all be well aware, across the health system, and how we look at different approaches to that. So how we work with health boards to get better planning based on the evidence, develop those operating models that are different, and then that need a different workforce approach. Maybe look at, again, I know it's a theme of a lot of the evidence, but increased use of digital resources and how workforces can look different. Again, that sits within the health boards and IGBs and others to deliver, but how do we create the framework that helps support some of those conversations and help boards do that? So we'll be looking at a lot of these issues within those contexts about how we can work with boards to think about what different workforce models look like. I mean, I think there's a lot around the professional mixes and looking at different psychologists, AHPs and others having a really important role in that. So we'll definitely be working with boards to look at how we can implement models that look different around all of this, recognising the points that the Minister's made previously about the need for a different approach.
One of the things that's raised with us in committee, and I'm sure other members will have it, is about the sustainability of the funding. And I wonder if the Minister feels that, long term, that we have, sort of security in funding for this as a long-term look at how we change services and how we make services improve for people. So is there any sort of thinking around maintaining funding but also giving some additional sustainable funding to change these models?
Well, I suppose there are 2 points to make. One is Gavin touched on with the Service Renewal Framework and that particular focus on prevention. That is, in terms of the whole health and social care system, is obviously going to prompt very detailed consideration of current funding arrangements and how areas are prioritised to ensure we are ensuring that focus on prevention is realised. Specifically, I could give an example of, as I touched on earlier, with the additional resource that has been provided this year of £500,000 in terms of supporting services, and that was part of the package I announced in my statement to Parliament back at the end of June, and hope to be in a position to set out further details in the utilisation of that funding shortly. So that is an example of what is taking place in year, and that builds on existing funding that has been provided previously, as well as, for example, the funding is provided through the Autistic Adult Support Fund as well. So there's a range of sort of funding streams. Part of it, of course, part of the wider settlements that are available to health boards, to local government, in terms of them delivering on their statutory responsibilities, but also specific targeted funding as well. But I would want to stress I recognise the importance around certainty and predictability of funding, and also the need to ensure that funding is matching what we're setting out in terms of pursuing a preventative agenda.
Thank you. I wonder just if I could have one last question. I know we're tight for time, but just that link between health and education is so important in this particular area, of course. And I just wondered whether you felt that we were working towards the implementation of the Autism in Schools Action Plan, and how you felt that was going in terms of that work.
Well, the link between health and education is vital, and it's why it's so important that in terms of taking forward the action set out in the implementation review, that the task force that's been established is representation chairing from health and from education. So that very much recognises the absolute importance of having that joined up approach specifically there, notwithstanding the exchange of comments I had with Mr Whittle about broader engagement as well. We can't have a siloed approach to this. And it speaks to the point as well with regards to the consideration around data, of not just specifically with health boards, but understanding the position with local government as well, and posing that challenge to ourselves collectively about how we can more effectively utilise that data that is there and is being generated. The challenge being how we can more effectively utilise that to ensure that we're meeting the needs of people.
Thank you. Thank you, Convener.
Thank you, Carol. Brian Whittle.
Thank you. Just on looking at workforce, I spoke to the Royal College of Psychiatry. Even though it shouldn't, a lot of the burden is falling on psychiatrists. They're not the ideal people to look at diagnosis of neurodivergence, but the burden is falling on them. And they were saying that the number of psychiatrists is on the decline. So that obviously is going to add even more pressure into the system and into psychiatry. So how are we developing a system where, one, that burden doesn't fall on psychiatrists, and two, we make sure there's enough employment in the system to deal with this increase in pressure?
There's work around workforce that has been undertaken. I maybe ask in just a moment, but just the point I wanted to make was that that's a really very profound point that is made in the paper that is published, and it speaks to the need of a stepped care approach, and one that is based upon need in looking at the opportunities for early intervention. And there will of course be cases where engagement with a psychiatrist is appropriate, and that is consistent with meeting an individual's need. But we know that there will be also many cases where needs can be met and support can be provided without the involvement of the psychiatrist in a way that perhaps is occurring too frequently at the moment. So it's a point I recognise, and I also recognise the point that's been articulated with the Royal College in terms of the impact that is having on the sustainability of the existing workforce. But maybe ask Gavin to come in, maybe anything he wants to add, and also just a bit more broadly around workforce.
Yeah, so we've been undertaking a bit of work with the Royal College and psychiatrists just to look at not just the numbers. So we are looking to increase the number of, or we have been increasing the number of training places, so we're expecting some of those increases to run through. But working with them and a whole suite of different issues around the working, how we can work with more psychiatry more effectively, their working conditions, all those kinds of things. So we published a report earlier this year on this, and we're now working with the college on the implementation of all of that. So we're working really closely with them to engage some of those issues. But like you say, I think a lot of the things we're looking at around service design, and Lynn might want to say something, is about how we use other professions around that and make sure that we've got psychiatrists doing things that they can really add the value in, and making sure that we've got the right staff and the right workforce implementation. And again, we're working with boards to make sure that they've got the right, they're looking at that and they're thinking about that as they renew and revise and transform their services.
Yeah, I think what's helpful to consider in all of this is a lot of the points that we've raised is around the multidisciplinary support that's required to provide a whole systems response to individuals. If you take psychology, for example, we've got 14 applicants for every training place in Scotland, so there's not shortage of workforce supply for all professional groups, and you will have heard as well from other professionals like allied health professionals who have got significant skills to add within this space. And also we've heard raised about the support that our valued colleagues in the third sector can also help with this. And I think Emma Harper raised an important point about training as well. I was just checking there in terms of the NATE recommendations we have within NES, the training framework, which describes 4 practice levels that our workforce, if you think about trauma-informed training, for example, that it transcends disciplines and it's about the skills that people need depending on the contact they have with different clinical or population groups that they're trying to support. So we have staff that are skilled at informed level, skilled level enhanced, and then specialists. So what's important to think about is how do we provide training and support for the whole workforce so that we can have that whole system and multidisciplinary response and use the skills of the wider professional groups that can really add significant value to this space.
Elena Whittam.
I'd like to spend a wee bit of time thinking about data. So we've already heard a lot this morning about data gaps that we have and work that's perhaps ongoing at the moment to try and understand that at every local area. One of the things that I'm really interested in is I understand the robustness of the actual CAMHS waiting times data and how that is assessed by Public Health Scotland and presented. I think the area that I'm really interested in understanding, and I think the committee would benefit from understanding as well, is what impact did the national specification implementation and the focus on CAMHS waiting times actually have on neurodevelopmental waiting lists and the understanding of what that looks at a local level, because that's very different to the CAMHS waiting lists as we understand them. And I think that it would be helpful to kind of set out for us, you know, perhaps as you understand it just now, what impact has that had on neuro-CAMHS waiting lists?
I thank you for the question, Ms Whittam. It's a really important one. And I thank you as well for helping to clarify the distinction between CAMHS. I'm conscious that in the past there may have been some conflation between CAMHS and ND, and of course CAMHS is with regards to the waiting list and 18-week target, which is referred to as a specialist service for children and adolescents and young people with acute mental health conditions. Developmental conditions, as we all understand, are not mental illnesses, they are not mental health conditions. Of course, where there is someone has a comorbidity with a neurodevelopmental condition and a mental health condition, if CAMHS is the clinically appropriate pathway, then that is what we would expect, for an individual to be included as part of that measurement. But also recognising, of course, that the majority of children and young people who engage with mental health services do so at a community level. So I think it's a very important point to make. There's also, I think, the recognition that there's a degree of complexity, as we've touched upon, with the way in which potentially assessment support can be provided around particularly for children and young people with a neurodevelopmental condition, and the way that interacts with the statutory responsibilities of education authorities in being able to provide support, including additional support for learning within an educational setting. And that again speaks to the point, touched on a few times this morning, that Stephen made about the data that already exists within the system and being able to bring that to bear so that we're most effectively utilising it to ensure that needs are being met. You want to come in, Stephen?
I think it's taking me back in time to a period where the neurodevelopmental specification was a policy response to what we found when we asked the question, why is CAMHS not delivering the national referral to treatment target? And I think you understand that and you phrased it in your question. So it was essentially unmet need, and I think we, as Mr Arthur has described, we need a different response than the traditional NHS waiting times response. where within GIRFEC the support is provided universally, and then requests for assistance should be made to other professionals to draw towards that support and meet the child, young person, family's needs. So it's a very different way of measuring what good looks like, and I think that that's the challenge for us, because it's from a school, local authority up to national level. So I don't think the approach we've taken in CAMS, as Mr Arthur's described, is the right one to measure success in the neurodevelopmental specification. But I was very pleased that we led to develop it, because it was a group of young people who were being referred to the wrong place, who had quite different needs, and their needs were not being addressed.
Okay, so I think following on from that, what would be helpful to understand is the impact of implementing the national specification. What impact that had on lists, I think, because if we've heard from organisations, we've heard from individuals in the written submissions, that once that was implemented, their young person, or indeed they themselves, came off a list, but didn't go onto any other list. So there's actually a direct impact to people on the ground, I think, that we don't have the data yet to understand. So my question is that work that you're doing as part of the task force to work with boards, to work with local authorities and their partnerships in the schools, to actually understand what does that look like on the ground for individuals in each of those areas, and what does that data actually tell us about what the need is?
Yeah, that's it. That is it in a nutshell. It's about the work that we're doing is to be able to assess and understand the level of need, to ensure that we are responding to meet that level of need. CAMS, with the exception of where there's a comorbidity, is not the appropriate pathway for a neurodevelopmental condition. Needs can, again, I do not reiterate this point, so there's, for the avoidance of any doubt, I fully recognise the importance that is placed upon assessment and diagnosis for a range of reasons as previously outlined, but there is a real opportunity for need to be met without diagnosis. Diagnosis should not be a requirement for needs being met, and notwithstanding the points the committee has taken and evidence and has raised today about concerns that diagnosis has been used by authorities as a gatekeeping tool, that should not be the case. Needs should be met. So the point about the exercise that's been undertaken with health boards, with local government, is utilising that data that is available, so we have a fuller picture of need, and that can help us in terms of ensuring that the national specification is implemented and that need is met.
I think where it becomes tricky for individuals at a local level is the fact that for some people it will be CAMS that actually do the assessments once they get there. So that in itself feels a bit confusing. So if you're one of those individuals and your child comes off a list, but eventually, it's still the CAMS service that's perhaps delivering that service.
There is, but I think again, this is in terms of the developments of our understanding and being very clear that there's a clear distinction between a mental health condition and a neurodevelopmental condition. They are distinct, and a neurodevelopmental condition is not a mental illness, it is not a mental health condition. But someone who has a neurodevelopmental condition who also has a mental health condition should be able to access mental health support in the way that anyone else would be able to. So it's important that there's that point of clarity. And as I touched on in my earlier remarks, I think there has been in the past some confliction, and that probably just reflects the fact that there's evolving and developing knowledge and understanding as well. You want to come back in, Stephen?
Just to say that I think that's one of the outcomes that the task force needs to deliver, which is the clarity that people are looking for at a local level. I take your point about there's some professionals in CAMS who actually work in the emerging neurodevelopmental pathways, but do people understand that locally? And there are other professions, I think Lynn touched on this earlier, AHPs, educational psychologists, fantastic resource, others that could be trained to do this that are more available. Is that clearly understood locally? I think the answer is probably no, but the task force is doing the work to help areas take a framework, we've called it a pathway, and then implement that locally, and that would need a communications plan, of course, and work with partners so that families understood who they were to ask for the right help.
I guess my final question round about data would be about whether the Scottish Government would commit to collecting and publishing data on neurodevelopmental waiting times, but also understanding what the need is. So those data sets that we have missing, so gendered data, information around about co-occurring conditions that might be useful to understand from a GP's perspective. I have this, patient that has been diagnosed as being autistic and having ADHD. What other things should I be looking at as their general practitioner? Other conditions that they may be presenting with. So understanding the data that we don't have, because we don't publish, sex disaggregated data in this space, and I think it's something that we really need to start looking at. Is that something that the Scottish Government is looking at in terms of the task force undertaking on data?
In terms of the work we are taking forward in terms of understanding data, I want to consider what opportunities are for the presentation of that data. Just a caveat with the points that I've made previously about the sort of paradigm that we maybe think of with the CAMS referral in a sort of traditional NHS waiting list. Given the complexities that are involved in the range of interactions, it's probably not appropriate. So I would not want to commit to the committee to a particular mode or form of presenting data, but I certainly recognise the strong parliamentary and public interest in ensuring that there is the fullest availability of the information that is held, and I appreciate the work that the committee had undertaken in its engagement with health boards ahead of this inquiry and being able to present figures which I think are important and illustrative of the scale of demand that exists. So I would want to, without committing to a specific form or mode of presentation, is to assure the committee that in terms of the work that has been undertaken, I want to give full consideration about how more data can be presented and shared that is robust and is reflective and is clear, and ultimately can be deployed and utilised in a way to help ensure that the need is met.
Thank you.
Sandra Gohani.
Thank you. Just following on from Elena's questions, NHS Grampian is reported to not have the ability to separate out neurodevelopment cases for their CAMS data, and so couldn't provide the current length of their waiting list even if they wanted to. I've also been told by my colleagues that NHS Lanarkshire's data that was published in the Herald is actually incorrect, and when you call them, it is actually 2 more years than the 2 that they've stated. So what is the Scottish Government doing to ensure basic data like this is collected and published in a transparent way?
I'm conscious of the points that have been raised, and the comprehensive briefing that was actually sort of provided just before the inquiry was launched by SPICE as well. Ultimately, health boards have the responsibility with regards to these operational matters, as we understand, in their day-to-day work. But it speaks fundamental to the point I've made about the challenges that we have with data right now. And of course, it's not just within health boards that we'd be considering, it's also within local authorities and within educational settings. And that speaks to the level of complexity here, and why a traditional NHS waiting times approach publishing lists would
Sorry, forgive me, Minister, specifically on NHS health boards that should have this data.
But the point I'm making is that's why we're having that level of engagement with health boards, and we've previously written to all health boards data, and we're collating and assessing what has been what they have provided. What is important for me is ensuring that in undertaking that work is that we are utilising data that's already been generated, and any further data that has to be collected, it has to be for the specific purpose of ensuring that need is being addressed. So that is the work that we're taking forward. Stress that I recognise the importance that has been placed upon data and the variation that exists, which is why we are working with health boards to understand what data they do hold, and then that can help to inform in terms of any further action that we would want to go and take with regards to any collection of data nationally.
Okay.
And Joe Fitzpatrick.
Thanks very much, Convener. Thanks, Minister. In June, in the Chamber, I think you re-emphasised the commitment of the previous Minister for the Government to take forward legislation in this area. So it would be helpful to the committee, I think, if you could give us an update on where that legislation is sitting at and maybe when we could expect to see draft provisions.
No, I recognise very much the importance it is placed on the LDAN bill, and giving very. I won't reiterate the points that my predecessor made with regards to the rationale for the decision that was taken, but I would want to provide the committee with assurance that this fully commands my attention. I'm working on it, engaging closely with issues, and while I cannot commit to a specific time, that undertaking that was given by my predecessor to publish draft revisions still holds, which is one that I will honour.
Okay, I think it'd be useful for the committee to get an update, you know, as that progresses. I think that would be helpful, not just for us, but for other folk who have personal interest. On that point, one of the arguments I think which was strongest in terms of taking a bit more time than had originally been expected was to make sure that there was meaningful involvement with those people most affected, people with autism, people with ADHD, people with learning disabilities for the specific of that bill. How is that going? Are you managing to get that meaningful engagement? Is there plans continuing?
Yes, there'll be some specific engagement I will undertake with the panels that were established. But it's also featured as part of a wider engagement I've been taking with a range of organisations representing all interests that would be affected by the bill, and it is featured as a matter of discussion very frequently. So I would want to give the committee assurance that this is something I'm actively engaging with those with lived experience on as part of wider conversations pertaining to my portfolio, but there's also planned further specific engagement ahead of the publication of any draft provisions.
I think that's really appreciated, and I think I was almost going to come back on you when you talked about organisations, but you then, I think, made it clear that you are including people with lived experience, yes, people with personal experience. I think that's very, very important and will be appreciated by the committee. So, thank you.
Thank you. Can I thank the Minister and his officials for their attendance today and for their evidence, and I'm going to briefly suspend the meeting. The third item on our agenda today is consideration of two negative instruments. The first instrument is the National Health Service Superannuation and Pension Schemes Miscellaneous Amendment Scotland Regulations 2025. The instrument makes changes to the salary earnings bandings of the employee contribution tables from the 1st of April 2025 to ensure that the tiering of pay bands remains in line with annual increases in members' pay. It also delivers a number of other policy changes, as well as making a series of technical and miscellaneous amendments to the NHS pension schemes. The Delegated Powers and Law Reform Committee's considered the instrument at its meeting on the 30th of September and made no recommendations in relation to the instrument, although it did welcome that the instrument corrects errors the DPLR Committee previously identified in a 2023 instrument. No motion recommending annulment has so far been lodged in relation to the instrument, and I put on record that I'm a member of the NHS Superannuation Pension Scheme. Do any members have any comments? I propose that the committee does not make any recommendations in relation to this negative instrument. Are members content to note the instrument? Yep. Thank you. The second instrument is the Sports Grounds and Sporting Events Designation Scotland Amendment Order 2025. The instrument amends the list of designated sports grounds in Schedule 1 of the 2014 order to reflect promotion to and relegation from the relevant levels of the Scottish football pyramid and any relevant stadium name changes. This is in the context of police powers in relation to alcohol-related and other controls at football matches. The Delegated Powers and Law Reform Committee considered the instrument at its meeting on the 30th of September and made no recommendations in relation to this instrument. No motion recommending annulment has so far been received in relation to this instrument. Do members have any comments? I propose that the committee does not make any recommendations in relation to this negative instrument. Are members content to note the instrument? Thank you. At our next meeting on Tuesday the 4th of November, the committee will commence Stage 2 proceedings on the Assisted Dying for Terminally Ill Adults Scotland Bill, and that concludes the public part of our meeting today.